Good morning everyone. Today I am discussing about the tibia bone. Myself Dr. Ravi Keshri, and the tibia bone, it is the tibia bone. This is the tibia bone and it is the medial bone of the leg, and it is massive and transmits body weight from femur to the foot, and tibia is the bone which articulates with femur to form knee joint. Fibula does not take part in the formation of the knee joint, but tibia takes part in the formation of the knee joint, and it is homologous with radius bone of upper limb. Now the parts of the tibia bone. The tibia bone has an upper end, the lower end, and the shaft. The features: the upper end, this is the upper end, this is upper end, and it is expanded transversely and projected posteriorly. The upper end of the tibia is markedly expanded from side to side. It is expanded from side to side, to form two large condyle. The condyles are the medial condyle and the lateral condyle. The two large condyle which overhangs the posterior surface of the shaft. This is the posterior surface of the shaft. Now the upper end, this is the upper end. It includes the medial condyle, the lateral condyle, the intercondylar area, and the tuberosity. This is the tibial tuberosity. Now the medial condyle. I will discuss the medial condyle. It is larger than the lateral condyle. This is the medial condyle and this is the lateral condyle, and this medial condyle, it is larger than the lateral condyle, and its superior surface articulates with the medial condyle of the femur. This articular surface, it is oval, and its long axis is antero-posterior. The central part of the surface is slightly concave. See the central part of the surface, it is slightly concave and comes into direct contact with the femoral condyle. The peripheral part, this is the peripheral part, and this peripheral part, it is flat and it's separated from the femoral condyle by the meniscus, medial meniscus. The lateral margin of the articular surface is raised to cover the medial intercondylar tubercle. This is the medial intercondylar tubercle. Now the lateral condyle, this is the lateral condyle. The lateral condyle overhangs the shaft more than the medial condyle, and the superior surface of the condyle articulates with the lateral condyle of the femur. The articular surface is nearly circular. As in the case of the medial condyle, the central part is slightly concave and comes in direct contact with the femur, but the peripheral part is flat and it's separated from the femur by lateral meniscus. The articular surface has a raised medial margin which covers the lateral intercondylar tubercle. Has the raised medial margin which covers the lateral intercondylar tubercle. The posterior inferior aspect of the lateral condyle articulates with the fibula. This is the fibular facet, and here there will be the articulation of the fibula. The fibular facet, this is the fibular facet, and it is flat, circular, and is directed downward, backward, and laterally. The backward, downward, and laterally. Now the intercondylar area. This is the intercondylar area. It is a roughened area on the superior surface between the articular surface of the two condyle. The area is narrowest in its middle part. It is narrowest in its middle part. This part is elevated to form the intercondylar eminence. The intercondylar eminence, which is flanked by the medial and lateral intercondylar tubercle. Tuberosity of the tibia. It is a prominence and located on the anterior aspect of the upper end of the tibia. It forms the anterior limit of the intercondylar area. Inferiorly, it is continuous with the anterior border of the shaft. This is the anterior border of the shaft. The tuberosity is divided into an upper smooth area and a lower rough area. Now the shaft. The shaft of the tibia, it is prismoid in shape and it has three borders and three surfaces: the anterior border, the medial border, and the interosseous border. And the three surfaces, that is the medial surface, the lateral surface, and the posterior surface. The three border and the three surfaces are present in the shaft of the tibia. Now the border, the anterior border. This is the anterior border, and it is sharp and S-shaped, being convex medially and in the upper part, and convex laterally in the lower part. It extends from the tibial tuberosity. This is the tibial tuberosity above to the anterior border of the medial malleolus, to the anterior border of the medial malleolus below. This is the medial malleolus and this is the anterior border of the medial malleolus. It is subcutaneous and forms the seen. Medial border, it is rounded and it extends from the medial condyle above to the posterior border of the medial malleolus below. This is the posterior border of the medial malleolus below. The interosseous border or the lateral border, this is the interosseous or the lateral border, extends from the lateral condyle. This is the lateral condyle and extends from the lateral condyle a little below and in front of the fibular facet. This is the fibular facet to the anterior border of the fibular notch. This is the fibular notch and this is the anterior border of the fibular notch. The surfaces are the lateral, medial and posterior surface. The lateral surface, it lies between the anterior and the interosseous border. This is the anterior border and this is the interosseous border and this is the lateral surface. In its upper 3/4, it is concave and is directed laterally, and its lower 1/4, it is directed forward. The medial surface lies between the anterior border and the medial border. Anterior border and the medial border. This is the medial surface. This is the medial surface. It is broad and most of it is subcutaneous. Now the posterior surface. This is the posterior surface. It lies between the medial border and the interosseous border. It is widest in its upper part. This part is crossed obliquely by a rough ridge. This is the rough ridge and that is called the soleal line. This is the soleal line. The soleal line begins just behind the fibular facet, this is the fibular facet, and runs downward and medially and terminates by joining the medial border at the junction of the upper 1/3 and the middle 1/3. Now, the above the soleal line, this is the soleal line, the posterior surface is in the form of a triangular area. The area below the soleal line is elongated. It is divided into medial and lateral part by a vertical ridge. It is divided into a medial and a lateral part by a vertical ridge. A Newton foramen is situated near the upper end of this ridge. It is directed downward and transmits Newton artery, which is a branch of the posterior tibial artery. Now the lower end. The lower end of the tibia, this is the lower end of the tibia, it is slightly expanded and it has the 5 surfaces: anterior surface, the posterior surface, the medial surface, the lateral surface and the inferior surface. Medially it is prolonged downward as medial malleolus. This is the medial malleolus. The anterior surface of the lower end has an upper smooth part and the lower rough and grooved part. Its lower margin gives attachment to the capsule of the ankle joint. The medial surface is subcutaneous and is continuous with the medial surface of the medial malleolus. Now the posterior surface. Its lowermost margin gives attachment to the capsule of the ankle joint. The lateral surface. The lateral surface has an articular facet called the fibular facet. This is the fibular facet, which articulates with the lower end of the fibula to form the inferior tibiofibular joint, which is a syndesmosis type of joint. The inferior surface, this is the inferior surface, is articular and covered with hyaline cartilage and articulates with the upper surface of the body of the talus. Now the medial malleolus, it has 4 surfaces and one border, that is the inferior border. The 4 surfaces are the anterior, posterior, the medial and the lateral surface, and one border, that is the inferior border. The medial malleolus, it is short but strong process which projects downward from the medial surface of the lower end of the tibia, and it forms subcutaneous prominence on the medial side of the ankle. Now the attachment on the tibia. The attachment on the medial condyle, this is the medial condyle, and the attachment on the medial condyle. The semimembranous muscle is inserted into the groove on the posterior surface. The capsular ligament of the knee joint is attached to the upper border, which also gives attachment to the deep fiber of the tibial collateral ligament. The medial patellar retinaculum is attached on the anterior surface. Now the attachment on the lateral condyle. The iliotibial tract is attached to the flattened impression on the anterior surface. The capsular ligament of the superior tibiofibular joint is attached around the margin of the fibular facet. The origin of the extensor digitorum longus and of peroneus longus extend onto the lateral condyle near the fibular facet. The groove on the posterior surface of the lateral condyle is occupied by the tendon of the popliteus with a bursa intervening. Attachment on the intercondylar area. The following are attached from before backward. First, the anterior horn of the medial meniscus, then the anterior cruciate ligament, then the anterior horn of the lateral meniscus, then the posterior horn of the lateral meniscus, then the posterior horn of the medial meniscus, and lastly the posterior cruciate ligament to the posterior most smooth area. The anterior horn of the medial meniscus just in front of the medial articular surface. Second is the anterior cruciate ligament on a smooth area just behind the previous attachment. The anterior horn of the lateral meniscus to the front of the intercondylar eminence and lateral to the anterior cruciate ligament. Then the posterior horn of the lateral meniscus to the posterior slope of the intercondylar eminence. Then the posterior horn of the medial meniscus to the depression behind the base of the medial intercondylar tubercle, and posterior cruciate ligament to the posterior most smooth area. These are the attachment on the intercondylar area. Now the attachment on the tibial tuberosity. This is the tibial tuberosity. The ligamentum patelli is attached to the upper smooth part of the tibial tuberosity, and lower rough area of the tuberosity is subcutaneous, but is separated from the skin by the subcutaneous infrapatellar bursa. Now the attachment on the shaft of the tibia. Tibialis anterior arises from the upper 2/3 or less of the lateral surface. The lateral surface. The upper part of the medial surface receives the insertion of the Sartorius, gracilis and semitendinosus from before backward. The soleus arises from the soleal line. The soleal line also gives attachment to the fascia covering the soleus, fascia covering the popliteus and transverse facial septum. The popliteus is inserted on the posterior surface into the triangular area above the soleal line. Here is the attachment of the popliteus muscle is inserted. Now the medial area of the posterior surface, below the soleal line, this is the soleal line, gives origin to the pes flexor digitorum longus, while lateral area it gives origin to the tibialis posterior muscle. Anterior border of the tibia gives attachment to the deep fascia of the leg and its lower part to the superior extensor retinaculum. The rough upper part of the fibular notch, this is the fibular notch, rough upper part of the fibular notch gives attachment to the interosseous tibiofibular ligament. The capsular ligament of the ankle joint is attached to the lower end along the margin of the articular surface. Deltoid ligament of the ankle joint is attached to the lower border of the medial malleolus. This is the lower border of the medial malleolus where the deltoid ligament of the ankle joint is attached. Now the relation to the tibia. The lower part of the anterior surface of the shaft and the anterior aspect of the lower end are crossed from medial to lateral side by the tibialis anterior, then the extensor hallucis longus, then the anterior tibial artery, the deep peroneal nerve, the extensor digitorum longus and peroneus tertius muscle from medial to lateral sides. The muscles, the artery, the nerve and the peroneus tertius muscles. The lowermost part of the posterior surface of the shaft and the posterior aspect of the lower end are related from the medial to lateral side. The tibialis posterior, which lies in the groove, then flexor digitorum longus, then posterior tibial artery, the tibial nerve and the flexor hallucis longus. The lower 1/3 of the medial surface of the shaft is crossed by the great saphenous vein. Now the blood supply. Blood nutrient artery to the tibia. It is the largest nutrient artery in the body. It is a branch of the posterior tibial artery which enters the bone on its posterior surface. Now the clinical aspects associated with the tibia. The upper end of the tibia, it is one of the commonest site for acute osteomyelitis. Upper end of the tibia is the one of the commonest site for acute osteomyelitis. Tibia is commonly fractured at the junction of the upper 2/3 and the lower 1/3 of the shaft, as the shaft is most slender here. Such fracture may unite slowly or may not unite at all, that is non-union, as the blood supply to this part is poor, and this may be caused by the tearing of the nutrient artery. Sometimes a surgeon takes a piece of bone from the part of the body and uses it to repair a defect in some other bone, called as bone graft. For this purpose, pieces of the bone are easily obtained from the subcutaneous medial aspect of the tibia. The insertion of the Sartorius, gracilis and semitendinosus muscle on the upper part of the medial surface of the tibia help to stabilize the bony pelvis, as these muscles belong to 3 different compartments of the thigh and act as 3 guy ropes. Now, next is the meniscal tear. The medial meniscus is more prone to injury than the lateral meniscus, because it is firmly adherent to the deeper part of the tibial collateral ligament and gets compressed between the femoral and tibial condyle, so in forceful twisting it gets torn. Injury to lateral meniscus is less common because the meniscus is relatively more mobile, as the popliteus muscle is attached to it and it pulls the meniscus. This is all about the tibia bone. Thank you.